welcome to the deep dive. Today, we're tackling a really significant health issue,
Hmm?
the huge impact of smoking.
Yeah.
We've got a detailed medical report here, specifically a section from a textbook looking at atherosclerotic risk factors.
Right.
Our goal is really to pull out the key info, especially about blood vessel health,
Sure.
look at the data, how it works biologically,
Yeah.
and also touch on quitting.
Exactly. And, when people think smoking, lung cancer usually comes to mind first, which is obviously huge.
Sure.
But this text frames it as, and this is a quote, one of the greatest public health catastrophes of the last century.
Wow.
Yeah. And it's still a massive modifiable risk factor, especially, for vascular surgeons dealing with aneurysms, blocked arteries, stuff like that. So understanding it deeply is, well, it's critical.
Okay, public health catastrophe. That's really strong language. What makes the impact so catastrophic on that kind of scale?
Well, the numbers, they really paint a stark picture, this report. It says smoking is the #1 preventable cause of illness, morbidity, and death, mortality here in the U.S.
#1 preventable.
Yeah. Every single year, we're talking over 480,000 premature deaths directly linked to smoking.
Over 480,000. That's staggering.
It is. And the economic hit is huge, too. Over $300 billion a year. That's lost productivity, direct medical costs. It's just an immense burden.
Almost hard to grasp those numbers.
Yeah.
Nearly 500,000 preventable deaths yearly. Wow. But, it feels like maybe we hear less about smoking now than, say, 20 years ago. Has there actually been improvement?
Oh, absolutely. There's been real progress. Since that big Surgeon General's report back in '64, the rate of adult smoking has more than halved.
More than half.
Yeah. By 2017, the rate was down to 14.0%,
Yeah.
which was actually the lowest since they started tracking it properly in 1965. So definitely heading the right way.
That is good news. But 14%, that's still a lot of people, right?
Yeah.
Did that 2017 data show any, interesting patterns within that group?
It did, yeah. The report points out some pretty noticeable differences. For example, it was more common in men, about 15.8% compared to women, who were at 12.2%.
Wow.
And age-wise, the highest rate was actually in the 45 to 64 group at 16.5%, while the lowest was 65 and older, down at 8.2%.
That age thing kind of makes sense. Maybe older folks have quit because of health issues, or sadly.
Exactly. Or they've already experienced the consequences, unfortunately.
Yeah. What about race and ethnicity? Did that show differences?
Yeah. And this is where you see some really stark disparities. The highest rate, American Indian and Alaska Native people at 24.0%, which is quite concerning.
24%. Wow.
Yeah. Contrast that with Asian individuals, lowest at 7.1%. Non-Hispanic whites were sort of in the middle, at 15.2%.
And socioeconomic factors like education or income, did they play a role?
Oh, big time. A really clear trend there. The report found only about 4% of people with a graduate degree smoked.
Only 4%.
Yeah. But compare that to people with a GED, it jumps to almost 37%.
Whoa, huge difference.
Huge. And similar with income. Less than $35,000 annual household income. That group was over 21% smokers, but over $100,000 income, down to about 7.6%.
It really shows how deeply embedded these patterns are. Socioeconomics, education, they really link up with health behaviors.
Definitely. It's very clear.
Now, the report looked beyond just cigarettes too, right? Other tobacco products.
It did. So in 2017, looking at daily or some days use, cigars, cigarillos, those little filtered cigars, that was about 3.8%. E-cigarettes are 2.8%.
Okay.
Smokeless tobacco, like chew or snuff, 2.1%. And then pipes, hookahs, water pipes, around 1%. So cigarettes are still king, but other stuff is definitely out there.
And e-cigarettes, vaping. It's become so common. The report mentions those.
It does. They deliver nicotine in an aerosol, no burning tobacco, and they're often marketed as less harmful, maybe even a way to quit smoking.
Right. You hear that a lot.
And this is really key. No e-cigarette has actually gotten FDA approval as a way to quit smoking. And the U.S. Preventive Services Task Force, they looked at the evidence and basically said, nope, not enough proof to recommend them for quitting.
That's a really important distinction. So the perception doesn't quite match the official stance or the evidence for quitting.
Exactly.
What other concerns did the report raise about them?
Well, a big one is just the lack of long-term data. We don't really know the full effects of inhaling all that aerosolized nicotine and other stuff for years and years.
Right. It's still relatively new compared to cigarettes.
Precisely. And then there's the worry about young people, teenagers, young adults, getting hooked on nicotine through vaping, potentially creating a whole new generation dealing with nicotine addiction.
Yeah, that makes total sense.
Sure.
Okay, so let's shift gears a bit. Moving from the big picture stats to how does smoking actually damage the body? Specifically, blood vessels. The report gets into the biology, right?
It does. This is where it gets, well, pretty fascinating, biologically speaking. The report basically outlines three main ways smoking just wrecks your vascular system.
Okay, three ways. What's the first?
First is something called endothelial dysfunction. The endothelium is just the inner lining of your blood vessels. Smoking cuts down the availability of nitric oxide, which is crucial for healthy blood flow.
Okay.
It also ramps up nasty stuff called reactive oxygen species, and it messes with how well your blood vessels can widen when blood flow increases. That's called flow-mediated dilation.
Right.
And what's really concerning, even brief exposure to secondhand smoke can start causing this dysfunction.
Wait, really? So not just smoking yourself, but being around it?
Exactly. Even passive smoking starts that damage process. It's pretty immediate.
Wow. Okay, so endothelial dysfunction is number one. What's next?
Second, it creates a prothrombotic environment. Basically, it makes your blood much stickier and more likely to clot.
Stickier blood. Yep.
Yeah. It increases a substance called thermoxane A2, decreases another called prostacyclin. These affect platelets, making them clump together more easily. Smokers also have higher levels of things that promote clotting, like von Willebrand factor, thrombin, fibrin. And at the same time, they have lower levels of the things that prevent clots, like tissue plasminogen activator.
So it's hitting it from both sides, promoting clots and reducing clot prevention.
Exactly. It throws the whole delicate balance off. Plus, they show signs their platelets are just generally more activated. It's a setup for dangerous blockages.
That sounds like, yeah, a perfect storm for things like heart attacks and strokes. What's the third way?
The third key thing is inflammation. Smoking promotes a chronic state of inflammation all through the body.
Chronic inflammation. We hear about that a lot these days.
Yeah, and smokers have higher levels of inflammatory markers in their blood compared to non-smokers. Things like leukocytes, white blood cells, C-reactive protein, interleukin-6, TNF-alpha, all higher. And this ongoing inflammation is a major driver behind atherosclerosis, that plaque buildup in arteries.
So let me recap. Damage to the vessel lining, much higher clot risk, and constant inflammation. That's quite the triple threat.
It really is.
And nicotine itself plays a role too, not just the smoke.
Yeah, nicotine isn't just the addictive part. It has direct effects, too.
Right.
It acts like a stimulant for your sympathetic nervous system, a sympathomimetic, which raises blood pressure.
Okay.
It's also linked to insulin resistance, problems with how your body handles fats, lipid metabolism, and, like we said, endothelial dysfunction. So yeah, nicotine itself is part of the problem.
Sobering.
Yeah.
Even just the nicotine. Now, the report mentioned something interesting, an observation about where the disease shows up, comparing smokers and people with diabetes.
Ah, right. That's a pattern surgeons have kind of noticed clinically over time. It seems smokers tend to get blockages more often in the big arteries in the abdomen and pelvis, the aortoiliac area, and the main artery in the thigh, the superficial femoral. Whereas patients with diabetes, they seem to get blockages more often deeper in the thigh, the profunda artery, and down in the lower leg, the tibial arteries.
Interesting difference in location.
It is, but the report is careful to point out that really rigorous studies confirming these broad patterns across the board are a bit sparse. It's more of a consistent clinical observation.
Got it. So an observed pattern, maybe not definitively proven everywhere. Now, obviously, smoking harms more than just blood vessels, right?
Yeah.
The report covers other non-vascular effects.
Oh, absolutely. The list is long. Smoking is causally linked, like directly causes a whole bunch of cancers. Lungs, obviously, but also mouth, throat, esophagus, stomach, pancreas, kidney, bladder, cervix.
Wow.
And more recently, it's strongly implicated in liver and colorectal cancers, too.
So the cancer risk is incredibly widespread.
Hugely. And beyond cancer, it's linked to diabetes, cataracts, macular degeneration, that eye disease, COPD, asthma, even rheumatoid arthritis. It really damages systems throughout the entire body.
It just underlined how systemic the damage is. Okay, let's bring it back to vascular health specifically. The report looks hard at peripheral arterial disease, PAD.
Yes, and the link there is incredibly strong, well established. Big studies, like the Framingham study, showed smoking was a stronger predictor for getting leg pain when walking intermittent claudication than it was for coronary artery disease or stroke.
Stronger than for heart disease or stroke. That's significant.
Yeah. And another one, the Speedwell study, called smoking the single most powerful risk factor for claudication, more than diabetes or high blood pressure.
Just underscores how bad it is for leg arteries. The report also mentioned the Women's Health Study, Did that add more?
It did. It followed almost 40,000 healthy women, healthcare pros, for years, and it showed a clear dose response, meaning the more you smoke, the higher the risk of symptomatic PA.
Okay, dose response, how much higher?
Compared to never smokers, former smokers had about a 3 times higher risk. Women smoking less than 15 cigarettes a day, almost 12 times the risk.
12 times.
And smokers hitting 15 or more cigarettes a day, an incredible 21 times higher risk of developing PA symptoms.
21 times. That is just astronomical.
Mm.
But there's good news here too, right? About quitting. Did that study look at that?
Yes, definitely. And the findings were really positive. It showed stopping smoking did lower the PAD risk. And even better, the longer you'd been smoke-free, the lower your risk got.
Okay, so it keeps getting better over time.
Exactly. Compared to current smokers, women who'd quit for less than 10 years had a lower risk. Quit for 10, 19 years, even lower. And if you'd quit for 20 years or more, your risk was getting pretty close to someone who never smoked at all.
That's fantastic.
Yeah. Now, it's worth noting, not every study shows the actual plaque shrinking after quitting, but reducing the risk of symptoms like this is still a massive win.
Absolutely. That's incredibly motivating news for anyone thinking of quitting. The report also gets into smoking's impact after vascular surgery, like on grafts failing or amputation risk.
It does. Really relevant stuff. A meta-analysis, that's where they combine data from.
Mm-hmm.
Lots of studies found smokers were about 2.35 times more likely to have their bypass graft fail after surgery on their legs.
More than twice as likely.
Yeah. And interestingly, when studies actually used tests to confirm if someone was really smoking, not just asking them, the risk jumped even higher to 3.8 times, suggests maybe some underreporting happens.
Makes sense.
And the analysis also showed smokers under 65 had an even higher risk of graft failure. Plus, it didn't matter if it was a natural graft from your own vein or a synthetic one. Smoking hurt both.
So it affects all types of grafts, especially in younger patients. But again, quitting helps here too.
Yes. That same analysis found former smokers had graft patency, the graft staying open that was better than current smokers, and importantly, it was comparable to never smokers.
Comparable to never smokers. That's huge.
It really is. It shows quitting makes a massive difference, even when you're already needing surgery.
What about heavy smoking and really severe outcomes like amputation?
Yeah, one study specifically looked at that. Patients having leg artery surgery were split into heavy smokers, 15-plus cigarettes a day, and non-heavy. The results at 3 years were pretty grim.
How grim?
Heavy smokers had a major amputation rate of 21%, compared to just 2% for the non-heavy smokers.
21% versus 2%. That's devastating.
Devastating. And their overall survival was significantly lower, too. It really hammers home how dangerous heavy smoking is for vascular outcomes.
Truly sobering figures. The report also briefly touched on other vascular diseases, not just PAD.
Right. Quickly mentioned the strong link to thromboangiitis obliterans, also called Buerger's disease.
Buerger's disease, okay.
Yeah, that's where smaller arteries and veins, usually arms and legs, get inflamed, clot up, can cause severe pain, tissue damage. Smoking is heavily tied to that. And also strongly linked to aortic aneurysms, those dangerous bulges in the main artery.
So right across the board for vascular problems, smoking is a major player.
Seems that way, yeah.
Okay, given all these risks, it makes sense the report finishes by talking about quitting smoking cessation. What are the key takeaways on how people can actually succeed?
Well, the number one thing is just that quitting has massive positive health effects. Improves your overall mortality risk of dying from anything.
That's the bottom line.
Yeah. And the report stresses that healthcare providers can make a difference, even with really brief advice, like just 1 minute of personalized counseling from a doctor can increase someone's chances of quitting successfully.
Only a minute.
Yeah.
That's encouraging. Less intimidating than thinking you need some huge intervention.
Exactly. It lowers the barrier.
So what approaches does the report suggest for doctors or nurses?
It recommends the 5 A's approach. Ask about tobacco use at every visit. Advise users to quit clearly and strongly. Assess if they're willing to try quitting now. Assist them if they are. Offer help. And arrange follow-up.
Ask, advise, assess, assist, arrange. Okay.
And for patients who aren't ready, there's the 5 R's for motivational interviewing, talk about relevance to them personally, discuss the risks of continuing, highlight the rewards of quitting, identify roadblocks and solutions, and repetition, bring it up again later.
Sounds like really practical frameworks. What about advice directly for someone trying to quit?
Some key tips. Set a firm quit date, aim for total abstinence from that day. Try to cut back on alcohol, since drinking is linked to relapse. Make your home and car smoke-free zones. Figure out your personal smoking triggers and plan how to avoid or cope with them.
Right. Identify those habits.
Exactly. And importantly, anticipate withdrawal. Mood changes, trouble concentrating, irritability, maybe nausea, headaches. Those
Mhm.
usually peak in the first week or two. Knowing what to expect helps.
Being prepared seems crucial. And medications. The report covers the FDA-approved ones.
Yes, several first-line options. There's nicotine replacement therapy, NRT gum, patches, lozenges, inhalers, nasal spray.
Lots of RT options. Yeah.
Yep. And then 2 non-nicotine prescription drugs, bupropion SR, brand name Wellbutrin or Zyben sometimes, and varenicline, which is Chantix.
How do those work, briefly?
Bupropion affects brain chemicals, dopamine and norepinephrine, and blocks nicotine receptors a bit. Varenicline works differently. It partly activates and partly blocks nicotine receptors.
Okay. And does the report say one is definitively the best?
Actually, no. It says there's no real consensus that one is universally better than others. It often boils down to personal preference, other health conditions, insurance, cost, those kinds of things.
Makes sense. Individual choice.
Yeah. And it notes these meds usually aren't recommended if you smoke less than, say, 10 cigarettes a day. But combination therapy can be really effective.
Combining them. Like what?
Like using the nicotine patch long-term over 14 weeks, plus a faster-acting NRT like gum or spray for cravings, or patch plus inhaler, or even the patch plus bupropion SR. Those combos often work better than one thing alone.
Good to know combining is an option, maybe even better sometimes. Did the report show data on how well these work?
Yeah, there's a table 11.3, that gives estimated odds ratios, basically, how much more likely you are to quit using an intervention compared to a placebo and the actual abstinence rates at 6 months.
Ah, so you can see the numbers.
Exactly. For instance, combining the long-term patch with gum or spray shows significantly better odds and higher quit rates than placebo. Varenicline alone also looks very effective for long-term quitting, according to that table. It's useful data for making choices.
Definitely helpful to see that concrete data.
Yeah.
The report wraps up by stressing the role surgeons play. That's interesting.
Yeah, it highlights that surgeons often have these key moments, these teachable moments, maybe before surgery, to really talk about quitting.
Right. When health is top of mind.
Exactly. But it says it shouldn't just be then, it should be ongoing. Surgeons should see tackling smoking as being just as vital for the patient's long-term health as the actual operation they perform.
Wow, as vital as the surgery itself.
Yeah, it's a powerful way to frame it. That addressing smoking is fundamental health care, not just optional lifestyle advice.
That really reframes it, doesn't it? Not just a bad habit, but a core medical issue that needs addressing, especially in vascular health.
Precisely. It's a critical part of the medical picture.
Well, this deep dive has been really eye-opening. I mean, the main takeaway for me is just the sheer scale of the damage smoking does, especially to the vascular system. And the evidence is just so solid.
It really is overwhelming when you look at it all together.
But just as importantly, the message that quitting works. It makes a real difference, reduces those risks significantly, and there are proven ways to get help.
Absolutely. The data on the benefits of cessation is just as strong. It's never too late to see improvements.
So thinking about this, something seemingly so common, like smoking, having such profound, widespread effects, it kind of makes you wonder, doesn't it? What other everyday habits might be having these big, maybe less obvious impacts on our long-term health?
That's a really interesting thought to leave people with.
Yeah. This whole discussion really highlights how important it is to understand the evidence behind these things and, make informed choices. Thanks so much for walking through this report with me. Really insightful stuff.
My pleasure. It's a crucial information to get out there.